a fourth-year medical student at the Arkansas College of Osteopathic Medicine. Today, I'll be presenting a case over a giant pilomatrixoma that was removed from the temporal scalp. So just a little bit of an introduction. A pilomatrixoma is a rare, typically benign tumor that originates from the hair matrix cells in the hair follicle. The reported incidence of diagnosis is anywhere between 0.001% and 0.0031% of all materials that are submitted for histopathologic examination, so it's very rare. It usually affects children and young adults, and the peak incidence of it being reported is in the second decade of life. However, it can occur in people of any age. It typically presents as a solitary, firm, slow-growing nodule that occurs in the head and neck region, but it's also been reported to occur on the trunk and the extremities. So although it is usually benign, it can occasionally undergo malignant transformation, or it can be mistaken for other malignant tumors, such as a basal cell carcinoma, squamous cell carcinoma, rhabdomyosarcoma, or metastasis from a different region in the body. So because of this, histologic examination is necessary to confirm the diagnosis. In addition, a giant pilomatrixoma is a rare variant of a pilomatrixoma, and it's characterized by its size, which exceeds 5 centimeters in diameter. So the case today, the patient presented to the ENT clinic after being referred from the primary care clinic to the dermatologist's office, and the dermatologist's office to the ENT clinic. So they presented with a nodule on the scalp that had been present for the last 8 months. On physical exam, there was a 6 to 7 centimeter firm, non-tender, well-circumscribed subcutaneous nodule. There was no ulceration or induration of the skin, and there was also no palpable lymphadenopathy of the cervical lymph nodes. So we obtained a CT scan of the head with and without contrast, and we found that there was a round, well-defined soft tissue lesion in the left frontotemporal subcutaneous scalp, and there was no invasion of the adjacent musculature or calvarium. There was also no significant enhancement of the lesion. You can see the physical exam findings and the CT scan findings in figure 1 and 2 up there. So all of these features suggested a benign lesion. So we brought the patient back and discussed the treatment options with them, and they ultimately elected to have the mass removed under general anesthesia. So after we removed the mass, we sent it for histologic examination, and that revealed islands of basaloid and ghost cells, which are dead keratinocytes that have lost their nucleus. And we also saw the occasional multinucleated giant cell and an area of calcification. And you can see the histologic findings right there in figure 3. So this pattern demonstrated the features of a pilomatrixoma, and because of the gross size of the lesion being greater than 5 centimeters, the diagnosis of pilomatrixoma was made. So in conclusion, this case highlights the rare occurrence of a pilomatrixoma, and although they are typically benign, they can sometimes be mistaken for malignant tumors, and they can also occasionally undergo malignant transformation themselves. So most cases of a malignant pilomatrixoma have been reported to occur on the head and neck and in the 5th and 6th decade of life, which was consistent with our patient's case presentation, which made it crucial for us to use histologic examination to rule out a malignant tumor. So because the features of a benign and a malignant pilomatrixoma are clinically indistinguishable from each other, we definitely needed to have a histopathologic diagnosis in this patient. Some histologic features of a malignant pilomatrixoma could include cellular atypia, areas of necrosis, nuclear pleomorphism, and numerous mitotic figures. So definitive treatment in these patients is surgical excision with clear margins. This can be achieved under general anesthesia, as in our patient, and some of these patients can also undergo the Mohs micrographic surgery. And then additionally, it is important for clinicians to kind of keep benign tumors such as a pilomatrixoma in their differential diagnosis for patients that present with these large scalp lesions, and then make sure that they undergo the necessary steps to rule out a malignant tumor, as many of these giant pilomatrixomas can be clinically indistinguishable from a malignant tumor. And that's all I have. Thank you.